Okay, I think we are all alive and well, and we're live on YouTube and we're recording. So I think we're ready to go. Thank you for joining us tonight. The participants that are on, thank you for joining us. And I'm excited to have such a wonderful panel of doctors with us. And so I'm going to turn it over first to Dr. Zekan, and then she will introduce our first speaker, and we will go from there. Thank y'all for being here.
Okay, good evening. And I'm sorry that my technology doesn't allow a visual, but I think most of you know who I am. I'm Dr. Patty Zekan. I've been with the Novant Health Cancer Institute for many years, too many years to count. And I've been with the Pink Ribbon Talk since their inception. I've just retired though, so I'm trying to kind of find this new life that is still going to include my interest and involvement in cancer services and Pink Ribbon Talks. I do want to welcome everybody. We were all disappointed that we didn't get to gather at the Mary Alice Warren Community Center last weekend in Louisville, and we're missing out on all the fun vendors, art, photo booth, coffee truck. I was really interested in that one. And the exercise activities that Julie had in mind, but we're going to pick up on that next year. I do hope everyone picked up their Survivor bag at Cancer Services, and I'm not quite sure what we did with the door prizes, but I'm sure that Lindy and Julie have gotten those into the right hands as well. Of course, it was the right decision to cancel due to that storm, because we always have as our goal that our participants remain safe and healthy. And certainly it was the safer thing to do to cancel that live event. While on the topic of safe and healthy, I'd like to make a push here for the COVID boosters. You know, we now have the new bivalent booster, which protects against the original strains, but also the Omicron strains. It's now available in this community. And the good news is you can get it at the same time you get your flu shot. So this is the time to get out and get both of those. And we encourage everyone to go ahead and do that. So October is Breast Cancer Awareness Month. And, you know, every year we get some new kind of celebrities who come forward with breast cancer awareness promotion. And this year it was Katie Couric. I think we were all a little bit surprised when we heard that she had been diagnosed with breast cancer, and she was very open about it, showing us a little bit of the personal side of how she felt when she was diagnosed. If you heard any of her interviews, you heard her fear. You also heard her express guilt. She had delayed having her mammogram done by about 6 months. And I do know that a lot of people delayed getting their breast cancer screening done during the 3 years we've now been experiencing COVID. And she felt guilty about it. And I really can't say whether her 6-month delay changed her ultimate outcome, but her sharing that emotion with us, I think, was very profound. But following her sharing fear and guilt, she also shared a very vibrant sense of hope. She expressed that breast cancer is curable. She expressed that if you get the right team surrounding you, there's a real good chance not only of cure, but having an experience that is not totally devastating. So what I at least took away from hearing Katie's message was, you know, number one, don't be afraid. Recognize that the negative emotions accompany the diagnosis, but don't let them linger. Move into a sense of hope, because the goal is cure. And most breast cancer patients will become breast cancer survivors. if you assemble the right team around you, some of which happens without your intention, it just happens, that team does have as its goal cure. In addition to cure, the team also has a goal of maintaining or regaining a sense of normalcy and a healthy life. So I'll just kind of list for you what I perceive as the team. It includes your primary care practitioner, often your gynecologist. It includes the breast cancer navigator, that wonderful nurse who suddenly appears like Glinda the Good Witch in The Wizard of Oz and finds you at the time of crises and decisions and helps you make the right decision to get you the dreaded news about a callback for an abnormal mammogram, that the radiologist plays a role at several pivotal points in your management and follow-up. And then there's the pathologist. We're going to have a pathologist on the panel tonight, and I call the pathologist the stealth member of the team, because you never attach a face. Even in today's webinar, there's not a face attached to the pathologist. And yet the information that that pathologist gives us is absolutely critical and pivotal in understanding your stage and your prognosis and your decisions that you need to make with your doctors about management. So recognizing that they're a key member of the team is really important, and I'm so glad we have one on the panel tonight. Then there's the surgeon and the reconstructive surgeon, who probably are the real team captains, because they're the people who actually get rid of the cancer. The surgeon's pivotal in helping you make the right decision about breast conservation and reconstruction. Then there's your medical oncologist, who's the person who helps you understand the need or lack of need for chemotherapy or hormonal therapy. And they also generally are the person who follows you the longest until you eventually are seen in a survivorship clinic by people who are supervised by the medical oncologist. Then there's your radiation oncologist, who also works in conjunction with the surgeon to help determine, what the right initial management of the disease is, and helps decide whether or not radiation therapy is going to play a role in that. Then we've got this other team of people whose goal is to try to help your life be normal and healthy. And it's your physical therapist, lymphedema therapist, sometimes occupational therapist, and your nutritionist. So that's quite a team. So one diagnosis suddenly, engenders the need for this huge team to kind of help you get through at least the initial phase of what's going on. Long term, the team becomes smaller. When cure is not possible in the small number of patients who we are unable to provide curative therapy for, we do recognize that research has identified therapy that is really advancing at an incredible pace. And the goal of therapy is that even with uncurable breast cancer, it's not necessarily a diagnosis that is going to result in fatality. In many instances, the disease is converted into a chronic disease, one like diabetes or hypertension that we live with and don't die from. So lots of new things have happened in every year that really have advanced our opportunity to offer excellent treatments for patients. And actually this year, the biggest thing is probably the newer targeted treatments that have come into our toolkit. So I would like to mention one other thing before I introduce the panel, and that is staging. I actually had a friend call today to tell me about a family member, and they were discussing their cancer diagnosis and repeatedly interchanged the word stage with the word grade. And Dr. Montoya in pathology will speak to us about the grade of a tumor. which is one of the features that we use when we try to determine the stage. But stage is a concept that is sometimes difficult for people to grasp, but an important thing for them to grasp. Staging can happen before surgery. It's a way of describing how extensive the breast cancer is. It includes the size of the tumor and whether or not we can appreciate any lymph nodes preoperatively, or whether it may have spread to distant parts of the body. Staging can happen before surgery, and we call that a clinical stage. Staging then happens again after surgery when we've got more information about the true size of the tumor and the true lymph node status, and we call that pathologic stage. But there are also more refined versions of staging, which include the hormonal receptor status that Dr. Montoya will talk about, and the HER2/neu status. And we use that information in addition to the clinical and pathologic staging to define a prognostic stage. And prognostic stage is really the most important thing you want to know, because it tells you and it tells your doctors the likely aggressiveness of the cancer and how you're going to do, in other words, your prognosis. So your stage may be a different number and letter as you move through the journey. And sometimes you'll even see that reflected when you read your notes in the chart. It may be one clinical stage before surgery, a different pathologic stage after surgery. And then later, as we learn more about the HER2/neu, we may refine it to a higher or a lower stage. So ultimately, when we provide our patients with their treatment summary and survivorship care plan, we do try to have the most accurate, most predictive prognostic staging available so that you do have that moving forward in your life. So tonight it's my honor to moderate the medical panel, and I'll introduce you to our medical specialists. We're going to meet Dr. Christine Pestana, who is a breast surgeon. We're going to meet Dr. Kelly Montoya, who is the stealth team member, the pathologist, and Dr. Kelly Reardon, the radiation oncologist. So I'm going to turn the baton over to Dr. Christina Pestana, who is with Atrium Health and our breast cancer surgeon.
Thank you so much. I'm just going to share my screen. And if you can just confirm that you can see that, please. I can.
Yes, that's good.
Perfect.
Thank you.
Thank you. So thank you so much for having me tonight. My name is Christine Pestana. I'm a breast surgical oncologist at Atrium Health, Wake Forest Baptist. And as we all know, we've been talking about it's Breast Cancer Awareness Month. And I just wanted to put a little plug in and remember all of our survivors and those who have been and continue to be affected by breast cancer. So first, let's talk about the impact of breast cancer. Breast cancer is the most common cancer in American women, regardless of ethnicity. It is the second leading cause of cancer death in the United States, falling short of lung cancer. The average lifetime risk of breast cancer for a woman in the United States is 12.3%, which equates to 1 out of every 8 women being affected by the disease. Unfortunately, every 50 seconds somewhere in the world, a woman dies from breast cancer. And this creates a major problem in our community. We must empower ourselves and others to ask, what can we do about this? It is really important to focus on breast cancer prevention, and while this is definitely ideal, early detection is quite valuable and can help decrease the amount of women who will die from breast cancer. So in order to prevent something, you'll have to know what your own risk is for it. So what are the risk factors for breast cancer? And I like to think of risk factors as non-modifiable risk factors or modifiable risk factors. And so non-modifiable risk factors are those that we cannot change. For example, we cannot change our age, the history of, if we've had a history of chest wall irradiation, for example, in a woman who has a history of lymphoma, our genetics, our family history, our hormonal history. So the age of our first period or when we go through menopause, we definitely can't change our breast density or a history of atypical breast lesions. But on the other hand, we do have some modifiable risk factors that we can all work towards to lower our risk of breast cancer. For example, inactivity, our BMI, not having children, although I think one's a little bit arguable since that's sometimes not something that we can control in some situations, smoking or drinking in excess, taking hormone replacement therapy, or choosing not to breastfeed, these are all considered modifiable risk factors for breast cancer. So many patients come into clinic and will ask, well, how can I decrease my risk for breast cancer? Or how can I decrease my risk of this coming back? And here are some examples. Exercise is definitely one of the most important lifestyle risk factors known to lower the risk of developing breast cancer. And it's also associated with lower relapse rates and better overall survival. So we can keep a normal BMI. A recent study was published which looked at the effects of obesity and breast cancer in Black and Hispanic women and suggested that a BMI of greater than 30 was an independent risk factor for developing the disease. In addition, the mortality from breast cancer was 35% higher for obese women compared with those of the normal body weight. The data collected by the Black Women's Health Imperative showed that exercise of 3 hours or more per week was associated with almost a 50% reduced risk of developing breast cancer. And that's a huge deal. So remember, exercise, maintaining a normal body weight, and avoiding things that are otherwise not great for your health are very important. Okay, so let's go back to risk assessment. So why is it important to measure risk? The purpose of this is to identify those women who are at an increased risk of breast cancer. And most importantly, not identifying high-risk individuals will lead to unnecessary morbidity and death. So what's the next step? This depends upon whether you're at average risk for breast cancer or at increased risk. And so here I've listed the NCCN guidelines for breast cancer screening. And as you can see, the first recommendation is to have a clinical encounter with a healthcare provider, which includes a breast exam and an ongoing yearly breast cancer risk assessment. It's also important to talk to both sides of your family, find out any history of any cancer and the age of diagnosis. And this will help to identify individual risk for breast cancer and subsequent screening strategies. So once you've done your clinical encounter and talked to your PCP, let's say he or she says, hey, you're at average risk for breast cancer. What's the next step? That's to get screened. Women who are at average risk should begin annual mammogram beginning at age 40. And remember, this is the best way to detect cancer early and is currently the best tool we have to save lives. And so we've all heard about different types of breast imaging, but which one is right for you? So the most common one we'll hear about is about the mammogram, which can be either a screening or a diagnostic tool. There are also ultrasounds and breast MRIs. And so what's the difference? What's the difference between a screening mammogram and a diagnostic mammogram? So screening are performed for women without breast complaints and at an average risk for breast cancer, and then you get the results in about 5 days. It's also really important to note and propagate that since 2010, the Affordable Care Act requires that insurance companies pay for screening mammograms in full. And then you have the diagnostic mammogram, which are used for women who have a new breast complaint, and they are also used to evaluate abnormalities on screening mammograms. So the radiologist is actually on site and gives you the result in real time, so any additional imaging can be done immediately. If there's an area of concern on a mammogram, this is often followed by a targeted breast ultrasound to further evaluate the area. And these may also be performed in high-risk patients or in patients with dense breast tissue. So we've done the clinical encounter and the screening mammogram, and the last important piece of the puzzle is breast awareness. So you need to know what is normal for you and report any changes to your providers. So for example, things to look out for are new lumps or hard knots in the breast, skin thickening or rippling, swelling, warmth or darkening of the breast, changes in the breast size, nipple crusting or discharge, or new onset breast pain. If you experience any of these, you should notify your physician immediately so diagnostic breast imaging can be ordered. So who gets an MRI? These are very sensitive tests, which can lead sometimes to unnecessary excessive false positive rates and biopsies. So they're generally reserved for high-risk women, and they are also significantly more costly than mammograms, so they really should be ordered for patients with strong indications. So now that we're talking about MRI, it begs the question, well, who is considered to be at increased risk for breast cancer? And these are patients with known BRCA1 or 2 mutations, have a strong family history of breast cancer, have undergone chest wall radiation therapy in the past, or have a personal history of atypical breast lesions. And what does that usually mean for a woman who's at an increased risk? Typically, these patients will undergo annual MRI in addition to their annual mammogram. And a general rule of thumb is to begin screening 10 years prior to the younger affected family member with breast cancer. And at this point, a genetics counselor, a referral to a genetics counselor would be considered so that the patient may have an extensive discussion about family history to determine whether she meets criteria for genetic testing. They will also be followed very closely with biannual physical exams is either with a primary care physician and or a gynecologist. And these high-risk patients also establish care with a breast surgical oncologist to follow them yearly. And that's really to initiate discussions about risk-reducing strategies, which can include lifestyle modifications, preventative medications, and even risk-reducing surgery. So the last thing I want to talk about is, well, what if there's something that's abnormal on imaging? What's the next step? That would be an image-guided biopsy. So either through a mammogram or ultrasound or MRI guided, and that's to obtain a tissue diagnosis. So if a patient is found to have cancer on a biopsy, an important step in her treatment will be to meet with someone like myself, a breast surgeon. And typically the surgeon reviews the pathology, discusses the likely treatment plan, and then that will obviously vary based upon the cancer stage. And so the way I like to approach these conversations is I usually divide into three main focuses. I will go over the surgical options first, either lumpectomy or mastectomy. Then we will talk about how we will stage her cancer by sampling axillary lymph nodes at the time of surgery. We will also discuss options for breast reconstruction and needs for genetic consultation if that's appropriate. And then usually the patient will also meet with a radiation oncologist and a medical oncologist. And so my goal as a surgeon is to ensure that the patient leaves my office feeling as though all of the questions are answered. She's at liberty to contact with any further concerns and has agreed with a formulated plan that marks the start of her journey to breast cancer survivorship. Thank you.
All right, I will go ahead and share my screen now. And
First, I'll introduce you. You're our stealth member of the team. Dr. Kelly Montoya is a surgical pathologist at the Novant Health Cancer Institute, and he's the person behind the scenes whose name ends up on your reports that you see in my chart that helps determine the actual unique characteristics of your breast cancer that help you and your team determine what is the best treatment for you to become a survivor. So Dr. Kelly Montoya.
thank you, Dr. Zekan. A couple of things. First, I want to just congratulate all of you out there. I know I can't see you. You can't see me, but congratulations on your breast cancer journey. And I wish you many happy years to follow. So pathology, we're the people that you probably don't even see our name because we try to bury it down at the bottom of the report. Because, you know, I got a joke for you, pathology joke. How do you tell an extroverted pathologist? And the answer to that is they look at your shoes when they're shaking your hand. So without further ado, so wait, I gotta click over here. Okay, there we go. And since Dr. Zekan said you wouldn't see me, I was able to find some pictures very briefly in that time. So the picture on the right is obviously myself. That was when I was a shadow of my former self when I took my first picture here at Novant back in 2009 when I was a resident. So
Dr. Montoya, we cannot see your screen.
Oh, okay. Let me see. There we go. Okay, now you can see my screen.
Yep, that's
okay.
Good. Thank you.
Sorry about that. Okay, yes. So yes, I have pictures of myself. That is who I am. And to the left is my wife and my kids. That was a couple of weeks ago over at Hanging Rock State Park. So a little bit about myself. I went to the Medical University of South Carolina, graduated in 2009. I did residency at Wake Forest and then stayed on for another year and did a fellowship in surgical pathology. My first job was in Tennessee. I was in Knoxville working at the Tenova facilities. And then from 2018, the job opened up here and we quickly took it because we have family in the area. So moving along. Okay, so pathology, what is it? Yeah, we have a rough idea sometimes. This is, I think, probably what other doctors think about when they sometimes see pathology. You know, I don't know if you watched this from the History Channel, Ancient Aliens. So, and then, you know, pathology, it's clearly socks. So, you know, the joke is you can flip the slide upside down and tell them it's a different case and nobody knows. But to us, they all have very distinct characteristics. And I just want to give you a brief overview kind of what we do and why we're here and why we're part of the team. So I kind of wanted to divide this up into three things. What is pathology? What does the pathologist do? And what goes into your pathology report? So when you get that report and when your doctors get that report, being your medical oncologist, your radiation oncologist, your surgeon, what information do they utilize and what does it mean to them? So what is pathology? Classically, the origin of the word is pathos, which is Greek for experience, misfortune, or emotion or condition. So it's the study of suffering, unfortunately, but in medicine, we use it as the study of disease. And our governing board, the College of American Pathologists, they practically define it as the medical discipline that provides diagnostic information to patients and clinicians. And that's a very broad definition. So this is also from the CAP. So we use gross, meaning what the surgeon takes out, the gross specimen, microscopic, immunologic, genetic, and molecular modalities to determine the presence of disease. We work closely with surgeons, radiologists, and oncologists. And for every subspecialty in medicine and surgery, there's a pathologist counterpart helping to make the correct diagnosis and guide the care of the patient. So what do we do specifically when we get your breast? And excuse me, there are some quote unquote gross images of fresh tissue. So I'm sorry if that, anybody has a little bit of an aversion to that, but I will be showing a few pictures. I've kept it to a minimum. So, but what do we do in the pathology lab? So on the left here, you have breast biopsies. This is what we'll get in the lab. And so sometimes, let's say they're looking for calcifications in your mammogram, they'll take a picture, an x-ray of your breast biopsies to make sure that they got it. So we then, this tissue goes through a tissue processor and it gets put onto these, what are called tissue blocks. And then they get made into slides. So this is a little bit of a oversimplification. There's a few other steps, but in general, this is what we do and what happens in the lab. So for breast resections, on the left, you'll get a lumpectomy. So your surgeon will take this out and you'll see there are wires that are through here. Those are the wires that the radiologist puts in, and those guide the surgeon to take out and adequately resect your breast mass. And then on the right, you'll see that we've painted it up nice and pretty. So the reason we do that is because we can orient this in space. And so under the microscope, we can see all of these different colors and we can guide the surgeon to make sure that they have adequately resected your breast cancer. So what we'll do after that is we will slice up the tissue. So we cut into it in thin sections and we take a look at it slice by slice and make sure that we have the cancer there. We'll look for the clip that the radiologist placed to ensure that that the tissue has been adequately resected. And so then the tissue goes into these little cassettes, not like cassette tapes, but these then go into the tissue processor. And as I showed you in here, then we embed them in paraffin wax here, and they get made into slides. And this is what we see under the microscope, okay? So we have just a couple of different examples of breast cancer. There's no quiz here. We're not gonna ask you which one is which, but this is generally what we see and what we're looking for under the microscope. Okay, so, sorry, I don't know what that I forgot to delete that under over there. But so now going along, talking about your report a little bit. So whether you had maybe DCIS or you had invasive cancer here, we go and we have certain things that we need to report for that specimen. We have a few other things. This is phylloides tumor, which is a different kind of tumor. We won't get into that here. Of course, I can take questions on that if anybody has any questions. But this are the guidelines from the College of American Pathologists, or the CAP, which help us to to make sure that we report everything that we need to for your resection specimen. And so this is just a PDF. You can see that. So for every one of these protocols, we have 42 pages of explanatory notes. We're not going to be going through that, but I just wanted you to know it is fairly extensive, the details that we have to report with your breast specimen. So what are the important points in your report? So the surgeon and the oncologist, they're going to want to know what the tumor is. Is it in situ or is it invasive? So in situ meaning, is it beyond the ducts? Invasive meaning, is it going into or invading into your actual breast beyond just the ductal tissue? The size, this will determine the stage. Dr. Zekan alluded to this earlier, the grade. So the grade is basically how does it look to us under the microscope? This usually, and I put that in brackets there, this usually correlates with the aggressiveness of the tumor, but it doesn't always. There are some exceptions, just as everything in life. The margins. So how far away is it from where the surgeon cut? So this is the reason that we ink the specimen, so that we can tell the surgeon how far away they are from the tumor on each of those margins. Did we find the clip that the radiologist placed during biopsy? Lymphovascular invasion. So this is tumor within vessels or lymphatic spaces. This indicates the potential to metastasize either to lymph nodes or other sites of the bodies. We have examined lymph nodes. So you'll sometimes hear about a sentinel lymph node. These are lymph nodes that the surgeon targets, so that potentially, if the tumor were to metastasize, it would go there first. We also report on receptors. So you may have heard of the estrogen and progesterone receptors and HER2. So these are all both prognostic, and these are potential for treatment and prognostic information for your surgeon and your oncologist, what they might treat you with. And then finally, we stage these, and this is back to the pathologic staging. So the oncologist or the surgeon may give you a clinical stage. We do a pathologic stage, and we use the tumor size, grade, and the receptors. So we take all this data to give you a prognostic stage, which is all inclusive. So tumor, is it in situ or is it invasive? So on the left side, I'm showing an example of in situ carcinoma, where tumor just fills up the ducts. And on the right, we have invasive carcinoma, where tumor is invading into the stroma of the breast. So it's beyond the ducts and going into the stroma. This is actually taken from this picture is actually taken from the same patient. So you can have in situ carcinoma and invasive carcinoma at the same time, or you can have either or. So size, I'm not going to go through this, but just know that size is important in what we will use to stage your breast cancer. So ranging from 1 to 5, 5 to 10, 20, 50, and then these other stages have a little bit more to do with some things like inflammatory carcinoma, which is kind of a clinical diagnosis. So this will help to determine your final stage. So grade, we talked about it. How does a tumor look to us under the microscope? We use 3 criteria to grade your tumor. Glandular differentiation. So how different does your tumor look from normal breast tissue? Does it have a lot of glands, which would give it a score of 1, or is it basically sheets of cells? That would give it a score of 3. Nuclear pleomorphism. So how ugly do the nuclei look to us under the microscope? And then mitoses. So mitoses are cells dividing, and we can see this under the microscope. I think I can go back here and show you an example Right here, that's a mitotic figure. So that's what it looks like to us when we see cells divide. So does your tumor have a lot of mitoses or does it have very few? And we add all these numbers up together and we give you a grade. And that is also useful in your overall prognostic stage. So, oh, sorry, I didn't mean to go back, but so this is describing the grade. So on the left, we have an example of a very well differentiated tumor, lots of tubule formation. And on the right, we have a very poorly differentiated tumor with lots of mitoses, big nuclei, big nucleoli, forming sheets of cell, I'm sorry, just poorly differentiated sheets without the presence of tubules. So margins, we talked about a little bit about this. This is how far away is the tumor from where the surgeon cut. So on the left, we have a negative margin. In the bottom left of this picture is tumor and is very far away. It's several millimeters away from the ink surface. Whereas here we have tumor that's approaching very close to the margin. So this information is very important to the surgeon because this indicates that they may either need to go back or the potential for additional treatment. And then this here on the right, this is actually what it looks like after they biopsy. So this is the biopsy site. This to make sure that it ensures that we actually got the spot that the radiologist biopsied. So lymphovascular invasion, we talked about this is indicating the tumor's potential to metastasize. Here we see tumor invading a little lymphatic space. And this is actually tumor within a liver. So this is normal liver up here, and this is tumor here. So, does the tumor have the potential to metastasize? Lymph nodes. So we usually get these with most of our breast resections. Does it contain metastatic cancer? The surgeon always likes to hear no metastatic cancer. Unfortunately, sometimes we find it. So this here down on the bottom is a tumor. Is tumor within the lymph node, and this is normal lymph node up here. So this cancer has unfortunately metastasized to the lymph node. And the receptors. So we have estrogen receptor and progesterone receptor. These are normal receptors in normal breast tissue. A lot of breast cancers will overexpress these, and these are used to help give the oncologist a marker of how aggressive the tumor, your cancer may be, but it also, especially with estrogen, gives them an idea of how they might treat you with anti-estrogen therapy. HER2, you may have heard of this. This is a membrane protein. If it is overexpressed, it used to be, well, it is a marker of a potentially more aggressive tumor, but the good news is we actually have targeted therapies for this. And so we will go and we score this quantitatively. Sometimes we can't do it just with these studies alone, and we have to do what's called FISH or fluorescent in situ hybridization. So sometimes we send it off. But these are the markers that we do routinely on all biopsies and or resection specimens for your breast cancer. And so staging. This, I just meant that, I know it's hard to read, but the goal of this was not to make you an expert in breast staging, but just to give you an overview of kind of what goes into it. So this is only 2 of 5 charts that are in our staging manual. And as we talked about with prognostic staging, it's a more holistic look to give you a final stage for your breast cancer. So we take into account things like the size, the grade, is it grade 1 or is it grade 3? The receptors, were your estrogen, progesterone, and HER2 positive or negative, and your lymph node status. This all goes into factoring the final stage of the final prognostic stage of your breast cancer. And with that, I think I am done. Were we going to save questions till the end, or I don't know if we had any.
We'll save the questions and
Okay.
they'll come in through the chat box or question and answer, and we'll have
Okay.
all the panelists available to, see and answer the questions that come in.
Very good.
But that was very good, Dr. Montoya. Thank you.
Thank you.
And next we'll hear from Dr. Kelly Reardon, who is a radiation oncologist at the Novant Health Cancer Institute. Kelly?
Hello, I'm Kelly Reardon. I'm going to try to share my screen here and make sure you guys can see it appropriately. Do you see that?
Not yet.
Okay, hold on. How about now?
Yes.
Okay, perfect. Let me see if it's going to go through here. Okay, so about me just a little bit. I am board certified in radiation oncology and president of our group here. I'm also the medical director of the Department of Radiation Oncology here at Forsyth and as well as Kernersville Medical Center. I did my undergraduate training at Virginia Tech, and me and my entire family are huge Hokie fans, which you can see down here lower. My dog here is even named Hokie. And then I did my med school and residency at the University of Virginia and stayed there for a couple of years as faculty. And I've been down here at Novant now for almost 6 years. And I specialize in treating breast cancer as well as head and neck malignancies. So I was just going to talk a few different topics about radiation therapy, just some changes and new things that have come out here recently. And so one of them is DCIS and the need for adjuvant radiation therapy. And so Dr. Montoya talked a little bit about this, about the differences in situ versus invasive breast cancer. But really, DCIS is the non-invasive form of cancer. So it is confined within the milk ducts. And so with that being said, it can't spread. So it doesn't have the ability to spread to lymph nodes. It doesn't have the ability to spread throughout the body. And so with that, really surgery is the mainstay of treatment for this. We want to just get it out before it potentially has the ability to become an invasive breast cancer, as well as I always tell my patients that a biopsy, I like to think as a snapshot of a movie. So you have a movie and you're playing it and you pause the screen, and that's kind of what the biopsy is. Just tells you kind of what you're looking at that moment. And sometimes you can see what the entire movie's about, but you might get surprised. So by taking out the DCIS, we make sure that there's no invasive breast cancer sitting right beside that DCIS. And so surgery is really kind of our mainstay, which consists of either a mastectomy, the removal of the entire breast, or lumpectomy, which is just removing that abnormal area and either adding or not adding radiation. So really, historically, radiation therapy was almost recommended for every single woman who had DCIS, and that was because it was really treated a lot like invasive breast cancer. But more recently, tests have come out that allow us to decide whether we even need radiation therapy. So there's this new kind of test that can be done, which is called DecisionRT. And what this is it's a risk assessment tool for women diagnosed with DCIS. So it takes the actual tissue that was in your breast, those precancerous cells, and it sends them off to a special lab. And what this does is it evaluates the patient's individual biology along with other risk factors to kind of come up with this personalized risk assessment tool. And what it's doing, it's going to predict the risk of a future DCIS or invasive recurrence in that same breast over the next 10 years. And so by providing this data, it helps you and your radiation oncologist decide whether radiation therapy is even necessary or will help reduce your risk of recurrence. So when this report comes back, it's called your DecisionRT score, and it's going to be reported on a scale of 0 to 10. And it'll also be categorized as low or elevated risk. And so this is an example of what you or your physician would see on your report. So this is for a person who has a low risk score. And so this number to me, it kind of puts it into low or elevated, but I don't worry so much about this number. This down here is what's important to kind of review. And so this is looking at what a patient's 10-year total risk of recurrence in that breast is. And that's going to be either it coming back as the precancerous cells or the invasive cancer. And so this is looking right here at what's your risk of with surgery all by itself, what the likelihood of it is coming back at that 10 years. And so this tells us this patient has an 8% risk of it coming back at 10 years. And if we add radiation, it only drops it to a 7% risk. And then this over here is looking at what the invasive recurrence risk is all by itself, not looking at precancerous too. And to me, this is our most important column to look at because invasive breast cancer is the one that has the ability to spread to lymph nodes, spread throughout the body, and actually affect your survival. So this is, to me, is our most important column. And for this, we can see this low risk patient has a 4% risk of it coming back at 10 years with surgery alone, and a 4% risk if we add radiation. So there's really no advantage to adding radiation to this patient. So a patient who historically would have been getting radiation, we were over treating. So this helps us determine we don't need it in this patient. Now, this is a patient that has an elevated risk, and you can see our numbers are different here. So this patient, for any recurrence at 10 years, it's a 28% risk. And by adding radiation, we can decrease them all the way down to a 9%. And over here, this invasive risk is a 20% risk. And with radiation, we decrease it down to a 7% risk. So for this patient may say that's a significant reduction. Let's add this radiation therapy in to kind of decrease my risk of this coming back. And so the next kind of topic I wanted to talk about is a newer radiation technique called accelerated partial breast irradiation. So when we look at breast cancer, approximately 75% of early stage breast cancer patients are eligible for what we call breast conservation therapy. And breast conservation therapy is when we don't perform a mastectomy, we're performing a lumpectomy to keep that breast intact. And so in about 25 to 50% of patients, there's reasons that we can't do breast conservation. So medical, cosmetic, or even the patient choosing just due to the worry of going back and getting mammograms every year. So some people choose not to do a lumpectomy just for personal reasons. And we know from multiple studies that survival outcomes are the same if a woman undergoes breast conservation or a mastectomy. And also, post-op radiation therapy after a lumpectomy has been shown to decrease the risk of recurrence as well as increase survival. I just talked about the decision RT, but this statement here is increasing survival is really for invasive breast cancer patients. And so radiotherapy in invasive breast cancer is really an essential component of breast conservation. A lot of times I'll get my patients to ask, why do I need radiation therapy? The surgeon said they got it all. And so kind of the best analogy I have come up with to kind of explain that is I like to think as the cancer as a weed and the patient as a garden. And then the surgeon, medical oncologist, and radiation oncologist are all gardeners, but they kind of have different jobs to do. So the surgeon sees the weed, goes in, plucks it up out of the grass, and throws it in the trash. But we know that weeds have roots. And even if we dig in that ground and we think we got every last piece, if there's a teeny tiny root left behind, it's going to grow right back. So radiation is kind of essentially weed killer to come in and spray that area down so that if there's any weeds there, we can kill it off and hopefully help prevent it from coming back. And then that medical oncologist is not only helping to deal with the roots, but also the pollen. So weeds can have pollen and it shakes off and goes elsewhere, and you could develop new weeds throughout the body, such as lung, liver, bones. And that therapy, whether it be an anti-estrogen like tamoxifen or letrozole, or whether it's even more aggressive with lots of pollen and you need chemotherapy, they kind of help treat it in that regard. So we look at adjuvant radiation, which adjuvant just means after your surgery. What are barriers to that? So they look and they see that about 15 to 30% of patients don't receive radiation after they have their lumpectomy. And part of that is convenience, whether they have access to a radiation facility, the worry of cost. One of my colleagues up at UVA did a study and showed that even distance from a radiation therapy facility, patients don't undergo because of the drive, because it is a daily treatment. Lack of social support, poor ambulatory status, all of these kind of things factor in to not receiving radiation afterwards. So really the question comes up then, can you get similar rates of local control with radiation if you only target the area of highest risk of recurrence? Rather than targeting the entire breast, can you do part of the breast? And so if the answer is yes, then radiation therapy could be delivered in a significantly shorter amount of time and making it more available and attractive to more women. And so this is really the concept of APBI, which is the accelerated partial breast irradiation. So when they've looked, studies now show that the majority of local recurrences really do occur close to the tumor bed. So they're within like a 2-centimeter area where that tumor was taken out, and not really, somewhere else completely opposite area of the breast. And so studies have shown now that, in carefully selected patients, the risk of recurrence is not different between doing partial breast and whole breast radiations. And so the advantage of this type of treatment, it's a shorter treatment time, and there's more normal tissue sparing because you're only targeting part of the breast rather than the whole breast. So not all patients are eligible, though, for partial breast irradiation. So even though it's a great and new technique, we have to use it selectively because other patients are at higher risk. So we do have 3 different categories of women for partial breast radiation. So we kind of break them down into suitable, meaning if you meet all these criteria, then you're a great candidate for partial breast. Cautionary means we should probably think about it. There might be some little higher risk features, but maybe if it's just 1 or 2, you would still be a candidate. And then unsuitable, that if you have these characteristics, partial breast radiation currently is not a great option for you because of your risk of recurrence somewhere else in the breast or in the lymph nodes. So really just the biggest is age. So women less than 50 are not great candidates just because, one, we just see the younger women have a higher risk of recurrence. If you don't have a BRCA mutation, your tumor size, which Dr. Montoya just kind of went over, those margins he talked about, the grade. This one is the biggest. One of the biggest is whether the tumor is just in one location or in more than one location of the breast. So if it's in more than one location, just treating part of the breast isn't a great idea. And then your nodal status. So if you have lymph nodes involved, it's not a great idea to do partial breast either, because we need to target those lymph nodes with the radiation therapy. These are cautionary patients, patients that if you kind of meet one, if you just have 1 or 2 characteristics, we might consider it, but we don't want to have multiple of these. And then unsuitable, so very young women, lymph node positivity, large tumors, because if you have a very large tumor, that lumpectomy cavity inside your breast, once you start putting margin on that for radiation therapy, you're essentially treating the entire breast. There's different ways to deliver partial breast radiation. And so these are kind of 3 of the ways here. So one of the ways to do partial breast radiation is with something called interstitial brachytherapy. And this is actually your radiation oncologist inserting needles within your breast and then delivering radiation through these little channels through this area. There's also something called balloon brachytherapy. And so this balloon is placed by your surgeon, and then the radiation therapy kind of comes up in through this catheter, which is sticking outside the breast here, and delivers radiation there. And then there's the external beam radiation therapy, and this says 3D conformal, but there's also intensity modulated. But all this is you're laying on the table and the radiation machine is coming from around you and treating your breast rather than it being delivered from the inside out. And so the differences are, this is a much more invasive type of procedure than this, which is even more than this if you're just getting a regular X-ray. Also, your radiation oncologist may be more proficient in one of the others and likes one more than the other. And then they may feel that one provides more side effects than the other, so they like a different one. So a lot of it's just your radiation oncologist opinion as to which type of partial breast they like to deliver. But where I talked about shorter treatment times, for partial breast radiation, this can range anywhere from 1 to 5 radiation treatments or 5 days of treatment. Whereas whole breast radiation, the shortest amount of time you're almost going to get is 16 and can range up to 30 days of radiation therapy. And so another big question that a radiation oncologist always receives is how many radiation treatments I'm going to get. And I just have to say for this is there's a lot of factors that go in when your radiation oncologist is determining the number of radiation treatments. So one we just talked about is whether you're a candidate for partial breast radiation or you need whole breast radiation. Another is you just need your breast radiated or do you need your lymph nodes radiated? And so that all factors into the number of treatments you're going to get. And no two patients are the same. So you may have a friend who got 16 and you come in and your radiation oncologist says that you need 30. That's just because your cancer is different than their cancer. And so we have patients that come in all the time that a different physician even has told them the number of treatments they're not going to get. But it really is looking at the pathology, determining how aggressive it appeared under the microscope, whether there were lymph nodes involved, all that kind of factors in. And some patients even need something called a boost, which is delivering extra radiation to right where that lumpectomy cavity is within the breast, or a little extra on the chest wall for a mastectomy patient due to high-risk features. And so really the takeaway point for me is patients are all different and you all deserve personalized care and decision-making. And your physicians, all of us are here to help you in those decisions and helping you make the right decisions and help guide you in those that are most appropriate for you.
Thank you, Dr. Reardon. So all of our panelists have now had an opportunity to present information to you. And if you have questions, we are all here to entertain answers to those questions. If you will present the questions, Lindy, help me out here. Is it in the chat or question and answer? Where are the questions coming?
They can put them in either place. I don't see any right now in either place, but you are welcome to put them. I did have a few questions emailed to me ahead of time. So I'll go ahead and start with those.
So all of the panelists should unmute their microphone to jump in. Is that how we're going to operate this?
Yes, I think that works the best.
Okay.
Okay, so I had a question sent in that says this person is 2.5 years into 5 years of anastrozole, not experiencing any kind of problems. What all is looked at during follow-up survivorship appointments, and how often are they necessary?
I guess that's a question that I should answer. Number one, anyone who is on an active cancer treatment needs regular follow-ups, and they can be anywhere from 3 to 6 months between visits. But the key to what is looked for during those visits is actually a directed history and physical. It is what the patient tells us. There are key questions we ask patients or key information we're looking for when patients are talking to us, just dealing with symptoms that might reflect either side effects of the drug or potential for a problem that might need to be investigated further to make sure it's not a metastasis. We usually don't check a lot of labs. It's usually examination of the patient, feeling of the breast, feeling of the lymph nodes, and then investigating any area of the body that they make us aware might be having a problem. The 2.5 years of anastrozole is halfway through the usual treatment program. There are some patients who we recommend longer treatments, up to 10 years, if they have a very high risk prognostic picture with their staging. Did that answer the question?
I think so. That's great. Okay, then another question was, if you are going for routine survivorship appointments, does it make sense to have your mammogram or your bone scan before your oncology appointment so that they have those results?
Not necessarily. Again, what I outlined with the previous question is that we really are going to examine the breast regardless. A treated breast never feels completely normal. The examination and the mammogram complement each other, but they don't have to be done in one specific sequence. The bone scan, we don't generally do bone scans in following up patients who are not having bone symptoms, but perhaps that particular question meant bone density, because we do monitor bone density in patients who are on anti-estrogens, because estrogen is part of the metabolism of the health of bones. And so often with these anti-estrogen treatments, we will see loss of bone density. So, but
Dr. Zekan? I've just lost her audio. Can anybody
Yeah.
else hear? Okay.
No, I can't. I couldn't hear her, but I think what she was trying to say is that looking at bone density is important when a patient is on hormonal therapy. And then, another thing we'll be looking at is if a patient's had a lumpectomy and the breast is still intact, then we'll usually get a mammogram on the affected side 6 months after completion of radiation, and then, every year after that.
Okay, another question just came in the Q&A, and it's saying that they had a lumpectomy and radiation and 2 years down the road. Should she continue to get diagnostic mammograms or
screening? That's
screening?
That's a really great question. It usually, what I've noticed is the radiologist will determine that. So they'll say, they'll give their recommendation at the bottom of the report, and then it'll say, screening mammogram in 1 year or diagnostic mammogram in 1 year. And the difference being, the diagnostic, that the day of, the patient will receive, real time results versus having to wait a couple of days for the screening.
I will say at Novant, just recently, this became a new guideline for us here in the system. And that is a great question, because this was brought up between medical oncology surgeons as to what we should be doing. So for that, we have determined that within the Novant system, if a patient has a normal diagnostic mammogram for 2 years after their lumpectomy with no new pathology, then they can convert to screening mammograms after that point. So it's a 2 year of diagnostic and then a screen after that.
That's great to know. Thank you.
Awesome. Another question is, we hear so much more about, the treatment's so much better. There's more survivors. People are living longer with metastatic, but that number of 1 in 8 women, that statistic has not changed in, I'm almost a 13-year survivor, and that's what the statistic was then. So I think it's been many, many more years than that. What does that mean, that basically the population is not doing the things they can to control lowering the risk, or why has that number not changed?
I can give what I feel responsible, or what the answer is, and then everyone else can chime in. But I think the screening mammograms are just getting better and better, and they're really picking up a lot of things that weren't able to be picked up before. You know, we're seeing really tiny lesions being picked up and diagnosed, which is really great. But I think that's why the number hasn't really changed.
Any other questions from the audience? I don't see any more in the Q&A or in the chat box, but before we let these doctors go, I want to make sure that you don't have any other questions. Well, thank you so much for being here tonight. We have recorded this session, so we'll send a link out to it, to the session for those who couldn't attend while it was live. A special thanks to Dr. Montoya, Dr. Pestana, Dr. Reardon, and Dr. Zekan for joining us. And I really appreciate you all being here. Keep an eye on the other Pink Ribbon Talks events we have for the rest of the month. We have a talk coming up next Thursday on health insurance, which I think is going to be really interesting. And then we have an art and wellness class coming up, as well as our monthly breast cancer support group, which we will have a speaker for that, talking about the importance of skincare. Well, if there's no other questions, then I am going to let everybody go.
Thank you very much.
Thank you.